Hello, everyone. This is Dr. Carrie Bedient with the Fertility Center of Las Vegas, back with another episode of Fertility Docs Uncensored with my two sexy, shining star, sensational co-hosts, Dr. Abby Eblen from Nashville Fertility Center.
Hi, everybody.
And Dr. Susan Hudson from Texas Fertility Center.
Hello.
So Christmas is in a couple of days. Are you both ready?
No.
I never feel ready. I always feel like I'm missing something.
I had someone ask me like the Monday after Thanksgiving, oh, hey, is all your Christmas shopping done? I'm like, what kind of monster are you? Who has their shopping done that quickly?
It's funny. So like my mom is one of those people who like kind of shops through the year for Christmas. But I promise you, she does not remember everything that she bought. So you end up like she ends up rebuying and you end up with lots of presents, which is, very nice and generous and everything. But I really don't think it like actually serves the purpose of the people who actually tried to plan.
I have the same problem. I like never can keep track of what all I've bought. It's terrible. Like a few days before, I'm like putting it all out, making sure everybody got their fair share, and it's challenging.
I don't know what I would do nowadays without Amazon though.
Oh yeah, absolutely.
Yeah. Do you guys have movie traditions?
I do.
Okay. What is the top ranking holiday movie that no holiday season is complete without? Granted, I think all three of us tend to do Christmas rather than other holidays, but what is the holiday movie that cannot be unobserved throughout the season?
Mine is White Christmas. Like that is the start of my Christmas season. So like when I pull out the decorations and we're putting up the tree and all that stuff, like White Christmas is on in the background. I've done that like ever since I was a kid. And we had a VCR tape of it and I'm pretty sure I wore out at least one of them as a kid.
That's awesome. Abby, what's yours?
Well, I would say probably Home Alone because it's always something that I want the whole family to kind of sit down and want to watch together. And everybody always even though I've seen it I don't know how many times, you always laugh at the dumb humor and when they fall and slip and hit their heads. And so that's probably ours that we watch the most is Home Alone.
What's yours, Carrie?
Our family, it's kind of rotating. We don't have an absolute diehard. I do appreciate me some Grinch. And I'm not a purist. It can be the very, very original. It can be the live human being Jim Carrey one. It can be the new one with Benedict what's his butt. But any of those are fine. Although my husband will swear by Die Hard.
My husband thinks that Die Hard is like the truest Christmas movie ever too.
I just don't think of that as a Christmas movie, but I guess it does take place over Christmas. So yeah, interesting.
Yeah, that is an ongoing discussion in our house of like, well, I mean, I guess I'll give it to you. I don't know that I've actually seen it all the way through. I have seen all of it, but I have not seen all of it in one stretch.
Yeah.
So the other one that we tend to watch too is Christmas Vacation because there again it's kind of a good just kind of family laugh.
Yeah.
But I will tell you if you've watched the unabridged version and you've watched the one that's like on TV, they're very different. So just be prepared if there's little ears around somewhere, as it starts out with every cuss word you've heard in the book for the first like 2 or 3 minutes of the movie. And I had totally forgotten that a couple of years ago. And there were little people around, and I was like, oh my gosh! But still a funny movie, but it starts out pretty raunchy.
I didn't think you knew all those words, Abby.
Oh, I've heard them a few times, but just on Christmas Vacation. That's the only place I've heard them.
Well, I'm glad you only pull them out for Christmas. That to me seems entirely appropriate. Usually in the midst of putting up the trees when all the words are or a Tuesday. Okay. Yeah. Susan, what questions do we have?
All right, we're going to do a couple of them today. Our first one is, hello there. Thank you so much for your show, which has been a huge support to me and helped me get down the path of discovering a polyp in my uterus, thanks to your episode on the endometrium. I've been suffering from secondary infertility for 18 months after a very easy conception of my first, who is age 4. I'll do the polypectomy, but then I have to decide. I proceed with the polypectomy and then try naturally again, or go through an egg collection cycle before surgery and then direct to IVF. All other indicators for both me and my husband are normal, and there is no clear explanation for infertility until now. Would appreciate your advice as to weigh my options. Try again or go right to IVF. Thanks.
So as always, size matters. And particularly in this kind of situation, because there are polyps and then there are polyps.
Yeah.
That is true.
And so if she's talking about like, a 0.5 centimeter or less, whatever, that's probably not the cause of your infertility. Now, if she's talking about a couple centimeters, then, I'll buy it.
Yeah.
Maybe not totally, but I'll buy it. So that's probably the first thing that I would want to know is how big is this polyp? And yeah.
What do you think, Abby?
Well, the one thing she said, she's either thinking about taking the polyp out and just trying on her own versus going straight to IVF. And she didn't really mention, although she may have already done this, but in between that, she could also go just on some ovulation induction medication with or without insemination. So, I mean, that would be an option as well. I think it depends a little bit, like Susan always says, it depends on kind of where you are emotionally and where you are physically. And I don't know how old you are, but if you've been trying for 18 months, I mean, if you quickest route to pregnancy is IVF, so certainly no one would, fault you for going that direction.
Yeah, I think there's some gray zone in between, trying naturally and trying, going straight to IVF, especially if there's no definable factor. Some of it is going to depend on your age and how many more kids you want to have too. If you're working on number 2, but you want to have 4, that's a different combination than, I'm working on my second and I'm going to be done and I'm, 34 and my 39 or 40. So,
yeah.
Yeah. The other thing to consider is that if you were not on any birth control in between the birth of your small human being and 18 months ago, even though you technically don't consider that as trying, your fertility doc does, because if you're not preventing, you're trying, short of absolutely not having intercourse, which no one's going to blame you as the parent of a toddler, but like an infant, a toddler. But that's the other thing to kind of throw in is that if you really haven't been preventing, this is actually more like 4 years of infertility. And that's a little bit different. There's, we just read an article in our maintenance of certification this year that has a really stellar table that says, if you are X years old and you've been trying for this amount of time and you have primary versus secondary fertility, this is the chance of you conceiving thereafter. And some of those numbers are really sobering, and they're very helpful in making decisions about trying spontaneously versus not. Okay, I'll be quiet now. Susan, what's our next question?
All right. Hi, docs. Love this show. It's been everything to me during my IVF journey. My FET is coming soon. I've had 5 children naturally. My last child is 12. I'm now 33, and I've had my tubes tied immediately after birth. What's the likelihood of transfer being successful after 12 years? I know the uterus is a muscle and it's had plenty of time to heal after 3 prior C-sections.
So did she mention what her age was?
She is 33.
33. So I would say a 33-year-old still has pretty good quality eggs. And, if you're going the route of IVF and you've had 5 children naturally, I mean, certainly there's no guarantees that you'll be pregnant. Some of the most disappointed patients I've seen after IVF are ones that had tubal ligations and thought their chances were like 100%, and it's not. But if you use a genetically normal embryo, I think in most of our practices, the success rate with a genetically normal embryo would be about 65%. I do think, though, and I'm sure someone's looked at your uterus, but I think probably you need to have a saline sonogram or something like that, just to really look and make sure that your C-section scars have healed appropriately. We tend to see that the more C-sections you have, the more likely you are to have just a scar that doesn't heal very well, and that muscle can be really thin and increase the risk of rupture. So I definitely would make sure that they look at that as well.
Single embryo transfer only.
Yes.
Without a doubt, with 3 prior
Absolutely.
C-sections, don't mess with a double.
And that fertility history too.
Yeah. Oh yeah. All right. Well, I don't know that I have anything to add beyond those 2. Susan, do you have anything to chime in?
No, I think that pretty much covered it.
All right. So this episode actually kind of ties in with our first question, which is, to what extent do you move forward with treatment? And so the little corner that we're going to focus on today is the types of treatment that you can potentially have with your OBGYN. And that's before you hit the infertility docs. And so I'm going to make the disclaimer right up front that not all OBGYNs, A, like fertility, B, are good or have any interest at being good at fertility, or 3, have the sometimes necessary equipment at their disposal to need to do it. On the flip side, for points 4, 5, and 6, some OBGYNs do, some OBGYNs absolutely love it, and they are very talented at it, and they have a high interest in it. So a lot of this is going to depend on what your particular OB wants to do, because OBGYN covers a huge volume of different care needs. And in the same way that some people are great at surgery, some people are great at babies, people are great at high-risk pregnancies, some people are really great at fertility, and then the opposite is always true as well. So that's the disclaimer.
So along those lines, to kind of get the conversation started, I think the first thing you do is make an appointment with your OB-GYN and have a very honest conversation with them. Be like, I'm trying to get pregnant. I'm concerned. And, do you have interest in doing fertility care, or do you prefer me to go straight to a reproductive endocrinologist? If your OB-GYN says, you need to go straight to a reproductive endocrinologist, our advice, I'm pretty sure I'm going to speak for all of us, is go to a reproductive endocrinologist, because there's something at play, either your particular history or the things that are at this particular doctor's disposal, that they don't think that this is necessarily going to be the best place for you to get your fertility care. So I think just asking that question is a very reasonable thing to do.
Well, and Carrie kind of touched upon this too. Not all OBGYNs are equipped. And by that, I mean, it's not their knowledge base. It's just they're not set up to be able to see patients 6 days a week and sometimes 7 days a week. Whereas, I always tell patients, sometimes they get really upset because they'll come to the practice and they won't see me. But I always say, we're different than everybody else. We see you when you need to be seen, not necessarily when I'm physically here in the practice. And so, I think with OBGYNs, it's really difficult for them to be able to treat patients based on when a patient ovulates. And sometimes that means procedures in the office on a Saturday that it's just not feasible or practical for them to do that.
Mm-hmm. And your fertility office knows at what point you need to see a physician versus just an ultrasonographer or a blood draw or something like that. And so there are a lot of times when, like Abby said, you're not going to see your specific physician, but you may not need to. Like, I don't need you to see me to get your ultrasound done. I just need the ultrasound done on that day. And then they're going to call me. I'm going to log into our system. I'm going to pull up those images and I'm going to look at them. Mm-hmm. And so it's a little different, and we are set up for that and we are primed for that. And a regular OB/GYN office oftentimes isn't, because their schedules just run very differently. No fewer hours for sure, but just differently.
Delivering babies and doing a lot of other stuff.
So what is the quick and dirty, because this is not the focus of this episode, but what are the quick and dirty things where if they have been found in you are not going to mess with your OB/GYN? Like, what are the straight to REI things?
Bad sperm, bad tubes.
No ovulation. Well, actually you might. Depending, yeah, you might. Age would be a big one. If if you've tried for 6 months or so and you're 35 or greater, you probably need to go to go to a reproductive endocrinologist.
Mm-hmm. And I would make the argument that 40 and over, it's a faster cutoff.
Yes.
To move to the REI and doing something more aggressive. Okay. So let's assume that someone has had all of her testing done and that her tubes are fine. The sperm is reasonable.
So testing would be HSG to look at tubes, or saline sonogram with tubal patency to look at tubes.
Mm-hmm. Having egg testing done, egg reserve, an AMH, day 3 hormones, a follicle count. Many OB/GYNs don't have the capacity for a follicle count because ultrasonographers outside of fertility office really don't care, nor do they have a need to care. You need to check the sperm. So let's say all that testing's been done and you don't meet the criteria we talked about. So you've got tubes, he's got sperm, all of the reasonable things. Your age is not 46 where you would have to go straight to an REI. What types of treatment do most OB/GYNs feel generally comfortable with?
Things like ovulation induction. So that would be basically for somebody who has irregular cycles would be the primary person, although sometimes we'll give ovulation induction just to augment what somebody else already does. So treatment with drugs that you probably heard of. Clomid, that's been around more than 50 years, is one option. Another drug called letrozole or Femara is another option. And essentially, they would kind of figure out, whether or not you're actually ovulating. So you would take the drugs for 5 days during the month, 3 through 7, 5 through 9, depending on your doctor. And then usually you would have timed intercourse, meaning intercourse around day 13, day 15, day 17. And then most OB/GYNs would probably want you to come into their office for a progesterone level. And that really tells them whether or not the egg really got released from the sac, the follicle that eventually becomes something called a corpus luteum. The purpose of that corpus luteum is to make progesterone. So about 7 or 8 days later, it's at peak performance. And so we should be able to measure a progesterone level, and that should sort of give us a little bit of a yes or no answer whether or not it worked for you or not.
So let's talk about the two specific medications in particular that the OB/GYNs are going to feel most comfortable in prescribing. So Susan, what's one of those?
So one of those is going to be letrozole. And letrozole is really the preferred drug nowadays for people who are not ovulating on a regular basis. And if you're in an OB/GYN's office, you're probably going to be doing maybe 1 or 2 of those pills a day for 5 days. And then they're going to do the monitoring like Abby described. For people who were trying to do what we call super ovulation, so you ovulate on a regular basis, then I think either Clomid or letrozole are probably reasonable options. I tend to use letrozole because it has less side effects and less risk of thinning the lining of the uterus, and a little less mood effects.
Yeah.
Which people sometimes really appreciate not having, and that type of thing. But Clomid is a tried and true drug. It's been around for a really long time, and so a lot of times that's really where the comfort zone for general OB/GYNs is.
So, and as a general rule, I just add to that too. Most OB/GYNs, at least in our community, and again, it's different, maybe different where you are, but in our community, usually they'll try for about 3 cycles. So if you ovulate on whatever drug they use for about 3 cycles and you're not pregnant, that's usually in our community when they kind of send you onto the REI at that point.
If you've done 3 to 6 cycles, that's probably a good time to maybe kick your treatment up a notch.
Mm-hmm. That's a good time to switch. So Abby, what's the mechanism? How does letrozole work? And then how does Clomid work?
So letrozole basically is called an aromatase inhibitor. It inhibits a little bit of your estrogen, decreases your estrogen level, and kind of tricks your brain into secreting more of the hormone FSH that goes down to your ovary, talks to your ovary, and helps the egg grow. Clomid sort of has the same end result. It actually blocks estrogen. So it blocks estrogen in the brain, and again, makes the brain think that there's not enough estrogen there. And so again, in response, you secrete FSH, and it talks to the ovary and makes the egg grow. One of the negative points for Clomid is it can also block estrogen in your blood vessels and give you hot flashes. I've even had men that were on Clomid that took it and got hot flashes, which is kind of funny. And then it also can block estrogen receptors in your lining. And something like 10% of women, they can have really thin linings. And I also tend to see sometimes if people are on Clomid for like 3 to 6 months, their lining tends to get thinner and thinner and thinner on the Clomid.
Okay. And then Susan, you were talking about side effects from each one. So what are the side effects that letrozole is known for, and what are the side effects that Clomid is known for?
So letrozole, sometimes you can have some mild hot flashes, usually not as significant as Clomid is known for. Letrozole does tend to make people a little tired. So I generally recommend taking it in the evening so you sleep through being tired. And
I've had a few people that are achy with letrozole.
Yeah, occasionally some muscle aches. Clomid is known for its mood swings. So sometimes those can be pretty substantial. With any of these I guess this is considered a side effect, but realize that there is a risk of multiples. Okay.
Mm-hmm.
Meaning you could be pregnant with multiple babies. Now, realistically, the risks are relatively low. So when people are just trying on their own, your risk of multiples is about 1%. And with letrozole or Clomid, it's probably somewhere in the 7 to 10% range. Okay. So it's not huge, but it definitely can happen. And so if you have any health conditions that would make multiples an even riskier pregnancy journey, because being pregnant with multiples is a risky pregnancy journey. But if you have something like, you only have a unicornuate uterus, or you have like high blood pressure and having to take multiple medications for it, or pretty significant diabetes or things like this, where, like I said, multiples might pose a huger physical risk to you, you might want to think about options.
Yeah. All right. And then when someone is taking Clomid or letrozole, how do they know if they've ovulated or not?
So I always joke and say the poor man's way to figure it out is if you don't usually have a 28-day cycle and you have a 28-day cycle, that tells you probably ovulated. But I think most of us do one of two things. Most of us would either do what I mentioned before. We check a progesterone level around day 21, 22, or 23. I think for me personally, if I'm pretty certain that the patient's probably going to ovulate on one of the treatments, I'll bring them in for ultrasound. And usually we bring them in for ultrasound around day 13 or 14 of the cycle, with day 1 being the first day of good flow. And the reason we do that is because ultimately, if the egg is just about ready to be released, we can't see the egg itself, but we can see the fluid filled sac around the egg, and we know that they're about to release it. So I think you can do it either way, but the reason I don't typically bring people in if I'm not real certain that they're going to ovulate, it's confusing. If you bring somebody in and you don't see a follicle, you don't know, well, do we bring them in too early? Did we bring them in too late? Have they already ovulated? And I think just sometimes for the sake of less confusion, I usually make sure that somebody's ovulating first by checking progesterone levels. And then with the subsequent cycle, a lot of times I'll bring them in for ultrasound to look.
At a general OB-GYN's office, there's going to be a handful of OB-GYNs that have the ability to have you come in for follicle scans. Most of them are not. Most of them are either going to just tell you do timed intercourse on these certain days, or use ovulation predictor kits. Pick your poison of the type you want to use, whether it's a stick or a fancy digital something or other, or, all those kinds of things. I think we have some episodes on that recently. And, that type of thing. But if you're working with your OB-GYN, there's going to be a few that do follicle scans. I have a few in my referring area that do, but most of them, I don't think that's going to be their practice, just because they don't have the flexibility. We all work on everyone's menstrual cycle. So it's kind of like we're always on somebody's menstrual cycle. So it just, that's the way our lives
have to be
work.
flexible. Yeah.
Whereas in an OB-GYN's office, they're seeing lots of well woman exams, they're delivering babies, they're doing OB appointments. That flexibility isn't really built in. Their flexibility is for other things and not necessarily that.
So with an ovulation predictor kit, does that work every single time? Particularly when you're taking like letrozole or Clomid or whatever?
No is the answer. Nothing ever works 100% of the time. Yeah, it works quite often though. And the patients a lot of times will say, well, I see this second line or the second bar. And what does that mean? Well, with a lot of those kits, it just means your estrogen level starting to go up. But what we really care about is the line that tells you you're actually just about to ovulate. So if you have one of those fancy digital ones, it's like a smiley face. And if you use the dip one, I think it's like, instead of one line, it's 2 lines. But that's basically how we can kind of figure out, if you ovulate. Sometimes when people have irregular cycles, though, it's really tricky. So if you have PCOS, a lot of times your luteinizing hormone stays elevated consistently all the time. And so if you find that you do those, even the digital ones, if you keep doing them and they always are positive, kind of the sign is, that's kind of telling you that probably you have a really high LH that's being picked up because the kit's so sensitive. So in that situation, you really can't use a predictor kit. It won't be helpful for you.
Okay. So what do you do if you do your first cycle of either of those medications and your predictor kit doesn't go positive, or it's always positive, meaning it's not reliable? Or you check that progesterone level afterwards on day 21 to 22, 23, and it's low, meaning you have not ovulated. You don't have a corpus luteum that's pumping out progesterone. What do you do in that case? What's your next step?
You need more medicine.
Bring on the drugs.
Bring
Bump
on
up
the
the
drugs.
dose.
So, and this is the point where, again, you know, kind of 1 pill, 2 pills, maybe 3 pills of either letrozole or Clomid, your physician may kind of bump you up to. But if you're not ovulating on whatever your doctor feels like is their kind of comfort zone as the maximum dose, that's when you really need to come see somebody like us, because we can do ultrasound monitoring, kind of know that these things are happening faster. Okay.
Mm-hmm.
You know, we'll do mid-cycle monitoring. It's like, oh, you have had absolutely no growth and you have 20 follicles on both ovaries and they're all about 6 millimeters. We just need to give you more medicine. And sometimes we need to use combinations of oral plus injectables. Most OB-GYNs are not going to be comfortable giving injectable medications for stimulation, just because of that really does start kind of kicking up that risk of multiples.
Yeah.
Mm-hmm. So when you have someone who has been seeing their OBGYN for just simple care, what's usually the max dose that the OB-GYNs in your area? And Susan, every time you say an OB-GYN, I just imagine a cute little cocktail with an umbrella made out.
Me too. I would say OBGYN. I don't know why. I guess
and it warms my heart
things.
every time I hear that in your sweet Texas lilt. So anyway, what are usually the max doses that OB-GYNs are going to go up to in these medications versus the doses that a fertility doc is willing to do?
I would say in our area, it's up to probably, we go 1 pill, 2 pills, 3 pills of Clomid, and 3 pills is usually the max for most OBGYNs. Most OBGYNs will do letrozole 2.5, which is 1 pill. They'll do 2 pills. Rarely do they do 3 pills, but I know of one person that does that that's an OBGYN, but otherwise, usually they stop at 2 pills of letrozole.
I'd say Texas does what Tennessee does.
Yeah, we're pretty similar.
Southeast sticks together.
I rarely see 150 milligrams of 3 tablets of Clomid. Most people are like, yeah, if it's not working with 2, off you go.
Yeah.
Okay. So what beyond just Clomid and letrozole can an OBGYN do in their office to help somebody out?
Well, this is kind of outside of the office, but the process can start in the office. If you have an ultrasound done and say you have something structurally wrong with your uterus, such as if you have a polyp or a fibroid interfering with the lining of the uterus. Again, some general OB-GYNs are going to want to do this. Some are not, but they can often do hysteroscopy to help improve the quality of the environment within the uterus, to help improve your chances with some of those initial measures. So you can have a surgical intervention. Sometimes if you maybe have evidence of endometriosis on your ovaries on ultrasound, again, depending on their comfort level on doing those types of surgeries, sometimes OB-GYNs will decide, hey, you have a big endometrioma, maybe we should remove that, kind of evaluate the status of your endometriosis.
All right. So we've got surgical stuff. What else? What other stuff do they have at their disposal that can potentially help? Other medications, things that they can give after ovulation.
Well, they can support the endometrium with progesterone. So if somebody ovulates on progesterone, or if we check their progesterone level and it's above about 2.5 or 3, but it's less than about 10, ultimately we kind of feel like they've ovulated, but maybe their corpus luteum is just not really pumping out enough progesterone. So a lot of times we'll support the corpus luteum by giving them some additional progesterone. And so OB-GYNs can certainly do that, and oftentimes do. And you would stay on that medicine all the way through the first trimester of pregnancy.
Mm-hmm. Especially if you have irregular periods, your OB-GYN may check your TSH level and your prolactin level. And if those are abnormal, they can medically treat those with medicines as well to get those back to more pregnancy friendly levels as well.
And also just looking at general health status. So in addition to the TSH and prolactin, which are defaults that we run when someone's got irregular periods, even simple things, looking at, are you severely anemic? Do you have diabetes? Is your blood pressure controlled? All of the things that you want to have in good condition before getting pregnant, they're going to be able to go through and check, because we'll occasionally find someone who has some unrelated infertility kind of issue. Diabetes is probably the most common of these, where once the diabetes gets fixed, life gets a lot better with respect to conceiving. And so between that and giving a recommendation of, hey, losing some weight could be really beneficial, those are also things that many OBGYNs are getting more and more comfortable with dealing, particularly with the weight loss help, and at least pushing you in the right direction to say, okay, let's try and work on XYZ so that we can get you ovulating. You can do it on your own, and you won't necessarily need the additional meds or technology or procedures that that can happen.
But Carrie, you make a really good point. Even if you're somebody that you're just sort of starting to think about, well, I think I'm going to get pregnant, or maybe we haven't been on birth control for a while and I don't know what to do next, definitely check in with your OBGYN, because kind of all the things that Carrie was saying are sort of under an umbrella of preconceptual counseling. And so OBGYNs are really good at looking at, is your diabetes under control? There's something we check called hemoglobin A1C, and we know it needs to be under a certain number before you can get pregnant. If you're on high blood pressure medicine, are you on the right high blood pressure medicine? Some of them can cause malformations in the baby. So those types of things, ideally, it's nice if you can check in with your OBGYN and get those things all straightened out before you really start to actively try, because that can become a problem once you get pregnant.
And I know we're talking about what can you get care at your OB/GYN's office, but if you do have any other chronic medical conditions, seizure disorders, that's one that we see a lot.
Crohn's disease.
Yeah.
Schizophrenia, bipolar, depression, all of those things.
You need to talk to your physician who's taking care of those medical conditions and be like, hey, listen, I am actively trying to conceive, and I'd really like to be on the best thing now for my pregnancy. Sometimes we get a little pushback in that they're like, oh, well, just let us know when you're pregnant. And I'm like, if you're actively trying to get pregnant, the best idea is to get stable on something and not try to make those adjustments when everything's all kind of quirky in your first trimester.
And one other thing to that end too, something that I know we all do when somebody presents to our office, but sometimes you may want to talk to your OBGYN about this as you start to get pregnant, and that's genetic testing to make sure that you and your partner don't carry the same recessive trait. It really, we do a test every time when somebody comes in the office, or at least to offer it. And it always surprises me. I mean, I just had somebody this week who had a really rare condition, and they both tested positive for it. And they say it only happens about 1 in 550 times, and maybe that's the case. But we found quite a few people that have the same recessive trait and had no idea. And so that's an issue, whether you're trying to get pregnant for 1 month or whether you've been trying to get pregnant for 2 or 3 years. So that's something that would be great to have done in your OBGYN's office. And, usually I think the one great thing about the OBs, I think the OBs in our community, and I know probably in Carrie and Susan's community as well, it's really a partnership. So they kind of start the process in this way. If it doesn't work, they send them to us. And then ultimately when a patient gets pregnant, we send the patient back usually at the 8 or 10 week mark to their OBGYN. So we really are in partnership. It's not a competitive thing at all. I mean, and what the OBGYN doesn't do as part of the workup, or if they don't do some things, then we just pick right back up with where they left off. So it's really a helpful mutual symbiotic relationship between reproductive endocrinologists and OBGYNs. So really utilize that.
Yeah, all great benefits. Anything else to add about any of the medicines that they use, any of the technology that they can use, any of the procedures that they can use, any of that y'all can think of?
I think those are kind of the big things. I mean, you'll occasionally have an OB/GYN's office who will do like inseminations and things like that. I think that was more common 10, 15 years ago. I think most of them have kind of pushed that off to the reproductive endocrinology world. And some of it depends on your region and how close you live to an REI and where those services are available. But again, back to what we started with, I think sitting down with your OB-GYN and really having a conversation about kind of, what you're interested in doing and what they, are comfortable in doing in their practice, and really making sure that everybody's on the same page.
Yeah.
Mm-hmm.
Expectations need to be met on both ends, I think.
Yeah. One of the things that I see a lot with people who come into my office who are on supplemental progesterone is that the concept is crystal clear and makes all kinds of sense. You need progesterone to support a pregnancy, you take it after you ovulate, and you're good to go. The problem with it is if you are taking it too long, it functions like birth control. And so sometimes I see patients who feel very unclear about when they should start and when they should stop taking the progesterone, particularly if they're not pregnant, because they say, oh, I've got 28-day cycles, I'm really routine. And then they start the progesterone and it throws their 28-day cycles, because while you're on progesterone, you're less likely to have a normal cycle. And so that's something to talk about with your OB-GYN. If they're going to put you on it, say, all right, how do I know when to start and how do I know when to stop? So
I
that
probably have at least one person every 2 months come in who takes progesterone on a daily basis, which I can tell you is a really bad idea when you're trying to get pregnant.
Yep, it's great birth control.
Well, the other thing about progesterone too is if, I've had patients that have come in and said, yeah, I'm having regular periods, and, you talk to them and they don't mention that they're on progesterone. And so you check a progesterone level and you're like, oh, your progesterone level is great. And they're like, well, I'm taking progesterone. So, if you're going to have somebody check your progesterone level, make sure that they are clear that you're also taking progesterone, because we check your progesterone level for different reasons. One is to see if you ovulate at all. And another reason to do it would be to see if we need to supplement it with more progesterone. And so just make sure everybody's clear that you're either taking it or you're not taking it, because it can be really confusing.
Mm-hmm. And sometimes some of the fertility supplements that you can get, particularly the creams, have progesterone in them. That counts.
Yeah.
And so make sure you know what's in all the substances, supplements, creams, anything like that you're using.
And let us know that you're taking those.
And let us know that you're taking it. We always appreciate that particular information.
We're detectives, but sometimes we're not that good of a detective.
Yes. It helps to know before you get the blood work back of, oh, I was taking this. Oh, that explains your results. Okay. So, all right, fabulous. Well, to our audience, thank you for listening. Be sure to tune in next week for more. Be sure to subscribe, leave us a review on Apple Podcasts. We'd love to hear from you. We're on Instagram, Facebook, YouTube. So hop on by, leave us a like or a follow, and say hello.
You can also visit fertilitydocsuncensored.com to submit specific questions you have about infertility. All questions will be answered on the podcast anonymously for our Ask the Doc segment, so don't hold back. We also love episode ideas, so let us know what you're thinking and want to hear.
And as always, this is intended for entertainment. It's not a substitute for medical advice from your own physician. All right, we'll talk with you soon. Bye.
Bye.